Welcome to part 3 of the series on hyper and hypovascular masses of the liver. In this screencast, we'll discuss some pitfalls or atypical cases that you should be aware of because you may encounter them in practice. I'm Joseph Owen. Thank you for joining. Again, this 3-part screencast has learning objectives, where at the end you should be able to distinguish the most common hyper and hypovascular masses, compare and contrast common benign and malignant masses, and then recognize some of the exceptions and atypical presentations of masses in the liver. Let's look at a case. Here we have an MRI image of the liver with all of our relevant sequences. We can see on our T1 pre-contrast image a hypointense nodule in the right hemiliver, which is very mildly T2 hyperintense. On the arterial phase, there's minimal arterial enhancement with some degree of progressive enhancement on subsequent phases of contrast. Notice that this does not seem to follow blood pool in terms of its enhancement or signal intensity. There also appears to be a small amount of capsular retraction. I would argue that this could be an intrahepatic cholangiocarcinoma, given its signal intensity and enhancement pattern. However, it's a sclerosed hemangioma. This was determined by a biopsy, and I encourage my residents and my colleagues in hepatology and surgical oncology to be very careful making a conclusive diagnosis of sclerosed hemangioma on imaging alone. These are often indeterminate. They have similar imaging features to malignant primary intrahepatic cholangiocarcinoma and metastatic adenocarcinoma. And I would encourage biopsy of lesions that are suspected to be sclerosed hemangioma. The one time you can be confident that something is a sclerosed hemangioma is if you can look back at prior imaging and see a classic hemangioma on prior imaging that has now changed in its appearance and has imaging features consistent with sclerosed hemangioma. Oftentimes, hemangiomas will sclerose after chemotherapy administration or as the liver develops fibrosis or cirrhosis. Let's look at another set of nodules. In this case, we actually have 2 nodules within the liver. We have a moderately T2 hyperintense nodule that is similar in signal intensity to subcutaneous fat. And we have an isointense nodule with signal intensity similar to the liver. When we look at our arterial phase, we see arterial phase hyperenhancement within the nodule that was isointense. And we see no real enhancement on the arterial phase of the T2 moderately hyperintense nodule. On portal venous phase, we start to see some peripheral nodular discontinuous enhancement. And of the isointense nodule, we see equilibration with background liver. That equilibration continues throughout subsequent phases of contrast. On the isointense nodule and the T2 hyperintense nodule shows progressive enhancement. That progressive enhancement is following blood pool to some degree, at least the nodule is similar to the IVC and aorta on the 2-minute delay. Notice on the hepatobiliary phase, there is uptake of Eovist within the T2 isointense nodule, and there's hypointensity within the T2 hyperintense nodule. You can see that hyperintense nodule on the DWI. It's also hyperintense on ADC, suggesting T2 shine through. So this first nodule is T1 hypointense, moderately T2 hyperintense, with minimal peripheral nodular arterial enhancement. There is some mild enhancement or mild retention of Eovist, but it is not near the background liver. And that's a hemangioma with Eovist. The enhancement pattern can be more subtle with Eovist when you're imaging hemangiomas, and that's because that liver will begin, a healthy liver will begin to take up Eovist early in that portal venous, and certainly by that 2-minute delay, and you can get rapid clearance of the blood pool. This isn't an example of washout, but with rapidly filling hemangiomas, you may sometimes see arterial phase hyperenhancement. Then the blood pool clears of contrast, and you will see what's called pseudo washout. So a lot of people would argue that if you think there's hemangiomas, or there could be a hemangioma, that you should consider an extracellular agent first, as opposed to imaging hemangioma with Eovist, due to the potential false positive of calling a rapidly filling hemangioma malignant, due to washout or pseudo washout. Here we have another mass, again, right hemiliver. We can see a background of steatosis on the opposed phase. It's moderately T2 hyperintense. We show peripheral nodular discontinuous enhancement. At the 10-minute, there appears to be Eovist retention, but notice the blood pool is not cleared. At 20 minutes, there appears to be some degree of Eovist retention. Again, the blood pool is not clear. Okay, so when you are trying to image a patient in the hepatobiliary phase with Eovist, you need to make sure that at 20 minutes, the blood pool has cleared of contrast. Some patients who have renal dysfunction and liver dysfunction, or one or the other, may clear Eovist more slowly from the blood pool. To have a true hepatobiliary phase, the blood pool needs to be cleared of contrast. So ensure that when you are looking at hepatobiliary phase, one of the first quality assurance steps you take is look at the IVC and aorta, make sure they are hypointense on your hepatobiliary phase. If they are not, you may need to wait another 20 minutes and acquire a 40-minute delay. In some patients with cirrhosis and chronic kidney disease, you may need to wait to 60 minutes. That is one of the challenges of using Eovist in patients with chronic kidney disease or chronic liver disease. Let's take a look at another nodule. In this patient, they were initially imaged with CT and not MRI. On CT, it was noted in the right hemiliver that there is a hyper-enhancing nodule that equilibrates with the background liver on the 3 to 5 minute delay. Because of its hyper-enhancement on this single portal venous phase, we did not have an arterial phase, and its equilibration on the 3 to 5 minute delay, it was felt to be a focal nodular hyperplasia. However, this person had a known primary neuroendocrine tumor. When we go to image it with MRI, we see a very different pattern of enhancement. On the arterial phase, there's little to no arterial enhancement, certainly not hyperenhancement. Again, minimal enhancement on the portal venous and the delayed, and it is markedly hypointense on our hepatobiliary phased imaging. Again, notice IVC and aorta void of contrast. It is T2 hyperintense, and it restricted diffusion. This ended up being a neuroendocrine tumor, metastasis to the liver, which was mistakenly called a focal nodular hyperplasia on the initial CT. Focal nodular hyperplasia will never be this T2 hyperintense, and it should not be hypointense on hepatobiliary phase. So in this case, the multiphase MRI without and with contrast and hepatobiliary phase really contributed to the care and diagnosis of this patient. Here we have a case of a patient with known neuroendocrine tumor that was widely metastatic to the liver. This was treated with bland embolization, so hepatic arterial embolization, a common therapy for neuroendocrine tumor. I would say that this post-treatment CT scan in the portal venous phase, if you only had the portal venous phase, you would say that there's little to no residual enhancement of these nodules or masses. And this was a good treatment response with little to no evidence of viable residual tumor based on imaging alone. However, if you looked at the arterial phase of this patient, you would notice there are numerous arterially enhancing nodules and masses throughout the liver, and many of the nodules and masses that appear to be simple cysts or areas of necrosis on portal venous phase show peripheral arterial phase hyperenhancement on the arterial phase. I believe when evaluating a patient with neuroendocrine tumor, it is essential to have a 3-phase MRI, CT, or preferably an MRI to assess for treatment response, because the enhancement patterns of neuroendocrine tumor are highly variable, and it is easy to miscategorize a patient as having progressive disease or stable disease or treatment response in the absence of a multi-phase CT or a contrast-enhanced MRI. Another difficulty with Eovist is isolated reports of Eovist retention in metastatic disease. The patient here on our left was found to have 2 small nodules in the liver that on hepatobiliary phased imaging showed this peripheral hyperintensity, which was felt to be Eovist uptake in focal nodular hyperplasia. However, the patient came back 1 year later, and it was noted that these nodules increased, particularly that central component that is not taking up Eovist had increased. Because of this increase in size over 1 year, these were biopsied and shown to be metastatic neuroendocrine tumor. This is another case where a patient had metastatic colorectal cancer that appeared to have some degree of Eovist uptake. Now, these patterns of uptake are not typical of FNH, but could be misattributed in people who were not aware that some degree of uptake, whether it's peripheral uptake around a metastatic nodule or some mild central uptake of a hypovascular nodule, can occur on the hepatobiliary phase with Eovist or Primovist. So be somewhat skeptical if you see an atypical pattern of Eovist uptake and you're worried about metastasis within the liver. Let's look at another case. Here we have T1, spoiled gradient recall echo, fat saturated, pre and post contrast imaging with Eovist. In the arterial phase, we see hyperenhancement relative to the liver. We see equilibration with the background liver on our portal venous, 2-minute delay. On our 10-minute delay, we start to see Eovist uptake within the mass, and on hepatobiliary phase, we see very clear Eovist retention or Eovist uptake. This closely resembles focal nodular hyperplasia. There was suspicion for hepatocellular carcinoma in this patient due to underlying risk factors, and this mass was biopsied and found to be a well-differentiated hepatocellular carcinoma. Eovist uptake can be seen in HCCs and adenomas. I will tell you in my experience, the HCCs tend to have a well-defined hypointense capsule around them on hepatobiliary phase, and they tend to be moderately T2 hyperintense, more than you would expect for that stealth lesion of FNH. They also tend to be mildly hypointense on T1. Here's a companion case that illustrates some of those points. Arterial phase, mild hyperenhancement, equilibration on portal venous, 2-minute delay, some mild retention on our hepatobiliary phase, but we see that well-defined hypointense capsule. And on our T2 weighted imaging, this is a well-defined mild to moderately T2 hyperintense mass. That is not typical of FNH. And so even though I would still provide FNH as within the differential on this mass, the T2 hyperintensity is very concerning, and this requires a biopsy. Here we have a completely different mass. In this case, we have arterial phase rim hyperenhancement, some mild T2 hyperintensity. We have progressive enhancement on our delayed phase. It's hypointense on T1 and it's markedly restricting diffusion. If you're in the LIRAD system, this would be a LIRADS M, so malignant but not necessarily hepatocellular carcinoma. One of the features that we see in this case are these small dilated peripheral bile ducts. That raises concern for cholangiocarcinoma. In this case, the patient had an elevated AFP with a normal CA19-9. This was biopsied and was found to be mixed type adenocarcinoma, sometimes referred to as biphenotypic tumor. And so this really falls under more of a cholangiospectrum in terms of treatment and prognosis. And it is important to recognize things such as subtle bile duct dilation peripheral to a mass and discordance of tumor markers, because you would not want to treat this like a hepatocellular carcinoma. That would result in a worse prognosis. Here we have a very interesting case. It was a 36-year-old man with alcoholism, presented with severe right upper quadrant pain, and at the outside hospital they had obtained a right upper quadrant ultrasound. We see two masses which are hypoechoic to the liver and impressing upon the gallbladder in hepatic segment 5. On CT, we see a nice correlate for the ultrasound findings with attenuating masses near the gallbladder fossa. Notice how well defined they are and the fact that they are somewhat exophytic and they have mass effect on the gallbladder. It's highly suspicious for neoplasm. The outside hospital thought that they were hepatic abscesses, which could be within the differential given their low attenuation and the right upper quadrant pain. When we obtained an MRI at our institution, we can see that these are near iso-intense on our T2 weighted imaging without FAT-SAT. They become hypo-intense to the background steatotic liver with T2 fat saturated imaging. On our in phase and opposed phase, there is loss of signal on the opposed phase relative to the in phase. And these masses are relatively hypoenhancing. This is most consistent with focal fat, which is somewhat atypical in this instance because of its exophytic appearance, its well-defined nature, and its mass effect on adjacent structures. But realize focal fat can do a large number of tricky things and can result in misdiagnosis. Sometimes it's diffuse, sometimes it's geographic, sometimes it's mass-like, as in this case. It could also be micronodular, and mimic cirrhosis or widespread metastatic disease. Let's take a look at this case of focal nodular hyperplasia. Focal nodular hyperplasia is going to have a little bit of a different imaging appearance in steatosis, but I believe once you're aware of its appearance when there is a background of steatosis, you can confidently make the diagnosis of focal nodular hyperplasia. So we have someone with severe steatosis in their background liver, and so their liver is mildly T2 hyperintense compared to what a normal liver would be. The focal nodular hyperplasia is not going to have steatosis within it. There is going to be fat sparing within focal nodular hyperplasia, and so it appears T2 hypointense to the background liver. Somewhat of an unusual finding. There are not many nodules that are hypointense to the background liver. We can see that it is mildly hyperintense to the background liver on our fat-saturated T2 weighted imaging. When we look at its enhancement pattern, first we have our pre-contrast T1 spoiled gradient recalled echo imaging here. And we can see because it's in the opposed phase and there's fat saturation, the liver signal intensity is low and the focal nodular hyperplasia remains high. So it's hyperintense relative to the abnormal steatotic liver. It does show arterial phase hyperenhancement, but instead of equilibrating with background liver, it remains hyperintense throughout all phases of contrast, including the hepatobiliary phase with Eovist. Because the background liver is so steatotic, it is going to be relatively hypointense to a normal liver on all phases of our spoiled gradient recalled echo T1 weighted imaging. And therefore, the focal nodular hyperplasia, which does not contain fat, will be hyperintense to that background steatotic liver. In summary, sclerosed hemangioma should be a diagnosis of exclusion. They can look like metastasis or cholangiocarcinoma, and I recommend biopsy if that's within your differential. Enhancement patterns of hemangioma can be atypical with Eovist. You can get early clearance of the blood pool causing pseudo washout. You can have abnormal arterial phases that may reduce your confidence in diagnosing a hemangioma. So many people recommend using a traditional extracellular agent for your first-line imaging. Well-differentiated HCC, adenoma, and some rare reports of metastasis have shown Eovist uptake. And before calling a focal nodular hyperplasia, I want you to look back at that T1, look back at that T2, pre-contrast, and make sure whatever you're calling a focal nodular hyperplasia is nearly isointense to the liver. If it is hypo on T1 or hyper on T2, consider some of these alternatives that can take up Eovist. Neuroendocrine tumor is highly variable. I cannot stress that enough. And having multiple phases on CT or having an MRI to assess for treatment response or to be sensitive for detecting metastatic disease during initial staging of neuroendocrine tumor, it's highly recommended. Focal fat can be very tricky. Don't forget it can be mass-like or micronodular in addition to the geographic areas or more diffuse steatosis that we are all familiar with. Focal nodular hyperplasia does not contain fat. It shows focal fatty sparing. So when there is a background of diffuse steatosis, it will be hyperintense on pre-contrast imaging, and it will remain hyperintense on subsequent phases of contrast, including your hepatobiliary phase. I know this was a little bit of a hodgepodge of different atypical presentations and exceptions to the rules that we learned in the first two podcasts, but I hope that these different examples are illustrative of the pitfalls you can encounter when imaging the liver, and I hope you find them helpful. Thank you for joining us. Consider subscribing to my channel for additional videos. Thank you for your time.